Coming up on the Doctor's Hospital podcast.
Because colon cancer is one of those cancers that is treatable and curable. There are some cancers, unfortunately, when they manifest themselves, they manifest at a very advanced state.
At Doctor's Hospital, our lamp just got brighter. The Loyalty Advantage membership program now has 3 unique plans to choose from. From Lamp Prepaid with free prime care visits and service line discounts, Lamp Insured with copay waivers and 0 upfront collections at the ER and inpatient services, or our new Lamp Access, a free plan that offers 10% off lab, pharmacy, and imaging. Lamp has a plan for everyone. To sign up, visit our website or give us a call. Doctor's Hospital, trusted and best care now.
Welcome to the Doctor's Hospital podcast. I'm your host, Alexis Burrows, Marketing Director at Doctor's Hospital. And I know we've been celebrating a lot of different awareness months in March, but today we are talking with Dr. Beverton Moxey, who is a gastroenterologist, and he's also the Vice President of Clinical Services. And he's here to talk about Colon Cancer Awareness Month, which also takes place in March. Welcome to the show, Dr. Moxey.
Great to be here, Alexis.
I want to say this is the first time we've had you on.
Yes.
Okay. I think we may have done a lecture here or there, but this will be the first time we've had you on the podcast, so that's good. So before we get into the nitty gritty of colon cancer and down that train of conversation, I always like to start the podcast by asking our physicians, especially, what made you decide to go into GI in particular? Out of all of the different specialties, subspecialties, why internal medicine, and then subspecialty, why gastro?
Great question. And thank you very much again for having me here with you today. So internal medicine, because an internist is the physician's physician.
Okay.
So I like to think that we are the smartest doctors out there.
Why the surgeons could fight.
But I enjoy internal medicine because it really gives you an opportunity to connect with people. And it also gives you an opportunity to have continuity of care. And so those are the things that I value and that I place great emphasis in. And so I think that being a part of somebody's journey to either continuing to keep them healthy or to getting them healthy is always a great thing. And it's one of the main reasons why I became a physician. In choosing my subspecialty, which is gastroenterology, I chose that subspecialty because it breaks up the monotony of the day-to-day office visits, and it gives me an opportunity to get in there. It's a highly procedure-oriented subspecialty, and so it gives me that difference of a practice rather than sitting down making that connection and with a patient in the office. It gives me the opportunity to play with some gadgets. And in gastroenterology, we have lots of gadgets that we handle. And also, it helps us with performing some life-saving procedures. Oftentimes we're called out for emergencies. It's not just about colon cancer. Sometimes patients have food impactions. They may have a fishbone that's stuck. They may be having a gastrointestinal hemorrhage where they're vomiting blood, seeing blood pass in the stool in a very profuse way. And we have to get in there, high adrenaline, locate the source and stop the bleeding. And so, it gives a lot of flexibility, provides some excitement as well.
Because like you said, you go beyond you use the word monotony, so I'll use it as well. But the monotony of the what could be the typical IM specialty, because then you deal with things like IBS, and a host of other, all of the things that come through when you're talking about gastro. So it does give you that difference in what the day-to-day looks like. And like you said, it does give you some procedural work as well in terms of on that side of the equation. So you mentioned colon cancer, and obviously with this being Colon Cancer Awareness Month, we're going to spend a lot of time kind of in that conversation. But let's start at the beginning. What would be some of the things that would put an individual at greater risk of getting colon cancer, and how do those risk factors play a role in people actually contracting it or developing it?
Okay. Again, great question. So when we think about colon cancer and risks, your family history plays an important part.
Hmm.
So if we have persons who have a first degree relative, and by that we're meaning brother, sister, or parent
Hmm.
that had colon cancer, especially at a young age, and young age, we're talking less than the age of 60, that
Wow.
automatically puts you in a different risk category from the average population. You're no longer considered average risk,
Hmm.
you're considered high risk. And so those persons, there's screening, there's data, and this is all evidence-based that shows that those persons should begin getting screened for colonoscopies and screened for colon cancer with a colonoscopy at
Hmm.
earlier ages. And so that's one of the major ones. Otherwise, patients also present with certain signs and symptoms. And so when we look at things such as you're noticing a change in your bowel habits,
Hmm.
for instance, if you are having a bowel movement every day, now it's taking you 3 or 4 days before you have a movement. If you're noticing that your stool shapes, if there's a change in the caliber of the stools,
Hmm.
meaning you were used to having um, nice form stools, now they're coming out in small pieces, now
Hmm.
they're coming out softer. Those are all very telling signs that there could be something going on within the colon that you should get checked out. If you notice blood, of course, that's an automatic need for a colonoscopy. Oftentimes, people would say, if they see blood, that, oh, this must be hemorrhoids.
Hmm.
While hemorrhoids are the most common cause of seeing blood, there are other causes that need to be thought about and that
Right.
are of greater concern, and so you should have that checked. If you go to the physician and you have an anemia,
Hmm.
and that anemia is not explained, and a case in point would be, we can't think of, there are few reasons why a male should be anemic.
Hmm.
And so if we, have had labs done in previous years and the labs show that our blood counts were normal and now they're low, why is that happening? And so even though you may not be physically seeing blood in your stool, you can be losing it microscopically, and we call that occult blood loss.
Hmm.
That's a reason. Unexplained abdominal pain. And obviously, if you do a scan or some imaging and it shows that there was an abnormal finding,
Hmm.
then those would all constitute reasons why you would want to come in and get a colonoscopy.
Right. I mean, it's interesting you mentioned early being pre-60. I think, you know, especially for somebody like me in my age bracket, I'm approaching 40. And you would think that early means like, pre-40, pre-50, prefer it to be pre-60, meaning that even what we see in people getting colon cancer and other forms of cancer pre-60, all of that is considered early. And I think sometimes that's a little bit of a disconnect that we may have, because I have so many stories of people that I know who are younger than that, who have developed different forms of cancer. So it's interesting to think about that in terms of how you consider what is early. And then speaking on early, you know, why is it so critical that we discover it early? Like if someone is at risk or is in the early stages of it, why is it important to find it out at that point? And then what are the ways that we can go about trying to detect it early?
Because it's so critical, it's very crucial to do that, because colon cancer is one of those cancers that is treatable
Hmm.
and curable. There are some cancers, unfortunately, when they manifest themselves, they manifest at a very advanced state.
Hmm.
However, colon cancer is one that once you catch it while it's contained within the colon,
Hmm.
you're able to actually have a cure, have curative therapy.
Hmm.
And there are some patients who may or may not, depending on the stage that they're diagnosed, that may not require even chemotherapy.
Hmm.
They may just require a resection of the lesion.
Hmm.
And at the time of surgery, the surgeon will also do a sampling of the lymph nodes that are in the surrounding area. And depending
Hmm.
on what those results show, then that will determine what are the next steps for treatment. Um, Going back to, what does a colonoscopy do? So the colonoscopy actually helps to detect polyps.
Hmm.
And most polyps actually are develop into cancer. Not all do, but most do. And when you see someone who presents with colon cancer with an advanced lesion, that typically is going on or has been going on for anywhere between 5 to 10 years
Oh, wow.
before you develop it to the point where it's actually a cancerous lesion.
Mm-hmm.
And so that's why the screening intervals are the way they are,
Mm-hmm.
and why we say start at a particular age. The previous screening age was 50.
Mm-hmm.
However, about 10 years ago, they actually changed that to the age of 45 in persons of African descent.
Mm-hmm.
And the reason why that was changed is because what we found was that at the age of 50, we were discovering more advanced lesions. And so there was a decision made by all of the relevant societies that we're a part of to say that, in this particular grouping, we should start screening at 45. Several years after that, there was a decision made that, and the guidelines were changed, that now this should be the screening age, meaning age 45 across all races.
Oh, wow.
So all ethnicities. And so because, as stated before, once they were able to gather more data, they were finding that it wasn't just persons of African descent who were being having more advanced lesions, but it was other groups as well.
Is there any indication in that research as to why it seemed to be developing earlier? Because in all groups, as you said, it's changed. So is there anything that's kind of indicative of what the reason is and what people may be able to do to kind of slow that possibility?
Yeah. So some of it is probably our lifestyle. So when you look at what are some of the things that really impact us, is it the way we're eating, diets? So if you have diets that are high in red meats, pork, lamb, liver, processed foods, we eat a lot of processed foods, the bacon, the sausage, whether it's coming in the form of pizza, buying a burger, all of those things put us at risk. Increase smoking. So persons, if they are, having more tobacco use, that's also an increased risk for a lot of cancers, and colon cancer is no different, as well as persons who drink excessive amounts of alcohol. That's also a risk factor. When we talk about more other risk factors, maybe to a lesser extent, our lifestyle. Do we lead a more sedentary lifestyle, a reactive, weight, obesity, being overweight? All of those things play a factor. And so I think, we may be seeing more persons develop these cancers early on, oftentimes because of modifiable risk factors like lifestyle.
Understood.
Genetics are genetics. They don't change. If
Right.
you have family history, that's just what it is.
So you mentioned family history earlier, and I wanted to kind of circle back to that as it pertains to screening and when you start. So you mentioned now, obviously, that for all ethnicity groups, the standard is that you should start screening at 45. How does that change if you do have a family history, and how often should the screening be done? So does it start earlier if you have a family history, and then what is the difference in frequency if you have it versus if you don't?
Okay. Again, another great question. So if you have a first degree relative, and we would have indicated earlier that's a brother, sister, or parent that was diagnosed with colon cancer less than the age of 60, the recommendation is that you start at the age of 40 or 10 years prior to the initial diagnosis. Okay. So for instance, if a father or sibling was diagnosed at the age of 58 or 59, you would get your initial colonoscopy at the age of 40. If a first degree relative was diagnosed at the age of 35, you will start at the age of 25.
Gotcha.
You will not obviously go to 40. So whichever is earliest. So it's either at the age of 40 or 10 years before
Prior
the
to
diagnosis being
Gotcha.
made.
Okay.
And that's for that grouping. And then once you start having your colonoscopy screenings done, you should get surveillance every 5 years unless you're directed otherwise by the physician. So what may change or what may lessen the screening interval, maybe if they did a colonoscopy on you and they found that you had an advanced lesion, or if you had multiple polyps, then they may actually say, come back in 2 years or 3 years. It all depends on what's found at the time of the colonoscopy.
I got you.
But you definitely would not go beyond 5 years.
In that instance. Okay. So when someone, has a suspicion that there may be something going on, and obviously if you have education such as this or in other forums and you say, well, that kind of sounds like me, like I've had some, blood in my stool, or I've had some strange abdominal pains. What is the journey from those initial signs to an actual diagnosis that says this is definitively colon cancer?
So the first thing I want to admonish persons to do is have a conversation with your primary care physician and say, hey, I'm noticing that I have these signs or symptoms, and they are concerning to me. Or in the event where you are not having any signs or symptoms, you are noticing that, you're at the age where you should be getting screened. And so you have a conversation with your primary care physician, letting them know that, and then they should refer you on to a gastroenterologist. In the case where you may not have a primary care physician, you can actually self-refer yourself to a gastroenterologist. I mean, there are several of us within the community. Just identify someone that you would want to attend to, go in, get a consultation with that person. And once a history has been taken from you in terms of your medical complaints, family history, etc., and a physical exam, then if you do meet the criteria for having a colonoscopy, I'm sure that one will be set up.
Okay, awesome. We're having a great conversation thus far with Dr. Beverton Moxey. We'll take a quick break for some words from our sponsors, and we'll be right back.
March is National Kidney Month, and Doctors Hospital is celebrating with a special offer just for you. For the entire month, we're offering 50% off kidney health screens. Take charge of your health and secure your future by booking your appointment today at clinics.doctorshosp.com. At Doctors Hospital, we prioritize your health, providing trusted and best care now.
And we're back, continuing our conversation with Dr. Beverton Moxey. So I know we talked a little bit about screening before, but I did want to kind of demystify the idea of what the different options are for screening for colon cancer. So I know at Doctors Hospital, we offer a virtual colonoscopy, and then you have the optical colonoscopy as well. But what other modalities are there? And then what are the use cases, or in which instance would you be best suited for an optical versus a virtual versus some other modality that may exist?
All right, good. Great question. And I get this all the time when patients come in. So let's first set the premise that screening means that you have absolutely no symptoms.
Okay.
And there are no signs, nothing that's worrisome on your labs or physical examination by your physician. And you actually have no family history. So if all of those boxes have been checked, then you fit into the screen category. So when we think about modalities, the gold standard is the optical colonoscopy, which is the one that most persons are aware of, where you drink a bowel prep, you go and you have an examination done that's done with sedation, where there's a colonoscope, which is a tube that examines your entire colon. Other options are the virtual colonoscopy, which is a newer technology. Again, not the gold standard, but it is an option that's available. It's done via CAT scan imaging. You still have to do the same prep. With this particular modality, you have a scenario where if something is detected, you're not able to actually treat it. Versus with an optical colonoscopy, if you do that particular modality, you're able to detect and remove polyps at the same time. With a virtual colonoscopy, there is an inability to do any treatment. So you will not be able to remove a colon polyp, and you will then be referred to have an optical colonoscopy done.
Understood.
Additionally, with the virtual colonoscopies, they only detect lesions greater than 1 millimeter in size, polyps. Most polyps are actually usually less than 1 millimeter. So now you have also the disadvantage of you're not being able to detect smaller polyps. The advantage, I guess, would be, or the with a virtual would be that it's a cheaper cost because you don't have to have sedation. You're not involving an anesthesia, personnel, and certain facility costs, but it's not what's recommended as the gold standard. Other modalities besides the virtual and an optical colonoscopy would be getting a stool test done. It's called a fecal immunohistochemical test, and that can be done on a yearly basis with your primary care provider, where you submit a stool sample that's sent to the lab, and it's used to detect blood that can be coming from a precancerous lesion.
Right.
Again, that has its inherent weaknesses as well, because it's not 100%. And then in addition to that, it's something that you're doing on a yearly basis. And again, if something is detected, now you still have to be referred to the gold standard test,
Right.
which is the optical colonoscopy, that allows really the clinician to see in real time if there's something in the colon and do something about it
At the same time. Right. I mean, this is why things are the gold standard, right? You have potentially, in a lot of instances, different options for screening, but there's a reason why the gold standard is what it is. And again, to reiterate your point, screening is an instance where there's no symptomatology, there's no family history, and you're just at screening age, correct?
Correct. And if you have any symptoms, and we can reiterate those again, change in bowel habits, blood in the stool, unexplained abdominal pain, unexplained anemia, or family history of colorectal cancer in a first-degree relative, the recommendation is that you proceed with having an optical colonoscopy. There should be no other modality that you should entertain.
Okay, understood. So we've talked about screening. We've talked about the process to diagnosis. So let's look at going beyond diagnosis and then into the treatment space. So for someone who's going through treatment for colon cancer, number one, what are some of the treatment options that exist, and where do they come into play? And then what are some of the expectations in terms of long or short-term side effects of going through a colon cancer treatment process?
All right, great. So what's going to be offered for treatment will be dependent upon the patient will be staged. So to walk you through it, you come in, you had some symptoms or not, and you refer to have a colonoscopy, and we go in there and we found that you had a mass. So what's going to happen is, if the mass is something that we're able to remove at the time of the test, we remove it completely.
Okay.
If we're not able to remove it, then we biopsy it, and we will also tattoo or inject around it. We mark it so that it's done actually with a type of ink called methylene blue that actually stains the colon. And what we would then do is, around where the lesion is, we would refer that person on to a surgeon that specializes in removal of colon masses, colon lesions that we suspect to be colon cancer. And so the injection or the staining of the colon allows them to easily identify where we actually biopsied. And so they're able to actually make their incision, and in a much smaller environment, it saves time for them in terms of during the time of the procedure, having to try to locate where this lesion could possibly be. During surgery, the physician will also look on the surrounding area where the mass was detected and see if there are any lymph nodes. And they remove the lymph nodes in those areas and they send them on for testing. And the reason why that's done is there's a communication with the lymphatics, and the lymphatics is what actually is a major part in metastasis of lesions and taking it from the colon to other parts of the body. And in the instance of colon cancer loves the liver. It commonly metastasizes to the liver. And so they want to make sure that there's no evidence of cancer in those lymph nodes, because that actually has, it's very telling as to what the next step should be. And that next step would be the patient needing to have chemotherapy. And so one of the things that we also do, so when I identify that there's a lesion and it's either removed or biopsy, I refer the patient onto a surgeon, a colorectal surgeon, and then I also send that patient to get a CAT scan of their abdomen and pelvis. And specifically, what we're looking for is to make sure that that lesion is contained within the colon, that we're not seeing any other lesions anywhere else in the abdomen, namely the liver. That would indicate that the lesion has already metastasized. So once the surgeon would have done their resection, look for lymph nodes, we would have had the CAT scan, we can actually give a staging. And that staging then determines what treatment modalities you need to have thereafter. And so it's done really in a multidisciplinary approach, because now the patient is then referred to an oncologist, and then the oncologist decides the regimen. We've now, medication is more advanced and more sophisticated in that the lesions are now, when you're doing the pathology and they're determining if somebody has a cancer or not, there are other testing that's done to actually, direct your therapy. And so we do other specialized testing on the specimen to determine to determine if we should have, directed therapy, like in terms of what the oncologist is going to use in their armamentarium. And so that helps. And so you want to give, so when you come up with the regimen, you want to give the client, the best chance. And
Right.
so, first impression is always, the best. So you want to hit the lesion hard.
Right. Gotcha. There was a point you mentioned there about colon cancer having a propensity to metastasize to the liver. So let's flip it in reverse. Is there cancer that exists in other parts of the body that typically like to metastasize to the colon, where if someone is encountering that they have, whether it's breast cancer or lung cancer or something else, where that's a likely scenario from the other way, where they should have that as a natural point of concern from a screening standpoint?
No, there's no cancers that will necessarily metastasize to the liver.
Good.
I mean, to the colon, sorry. But what you will find is that sometimes patients who may have certain gynecologic malignancies or anything that's in close proximity to the bowel, like maybe even a kidney, sometimes depending on what's happening with that cancer, what type of cancer it is, there can be some erosion into it, as opposed to necessarily a metastasis, meaning that it's the bowel is actually in close proximity to where the primary is. So in that instance, you may see.
Right. So it's almost
something.
like in that instance, it's almost like it rubs off on it, not necessarily
Correct.
travels down to it. Gotcha.
And what you will find as well is that when persons have breast cancer, we recommend that they get a colonoscopy, because there's close association between breast cancer, this is all genetics, breast cancer and certain gynecologic cancers and colon cancers. So we tend to see that those kind of go hand in hand. And so it's recommended that you get a screen if you are diagnosed with one of those malignancies.
Okay. Understood. All right. So as we wrap up our conversation, I have two more questions for you. The first would be, what are some common myths or misunderstandings that you've come across with patients regarding colon cancer, and how would you clear those up?
I think the most common myth that I come across is that it's a man's thing, and actually men and women are equally affected by colon cancer. And so the recommendations for screening apply to both across the board. I would think that people obviously have concerns about the prep. They don't know what to expect. They don't know, what to expect during a colonoscopy. They think it's some major procedure. And, once a person would have had a colonoscopy and they realize that the hardest thing about doing it is really drinking that prep solution. We tend to have a lot of converts, and people are back, and then they also share their experiences with their friends and family members, and they come. So I think a lot of times people just don't understand what it entails and what's going to happen. And so again, you're going to have that information being, brought to you in a way that you can understand once you visit a gastroenterologist. And so I just want to encourage everyone that's listening on this podcast that if you're of the age,
Mm-hmm.
go and have a conversation with a gastroenterologist. And definitely, if you're having symptoms, you should seek an individual out, as soon as possible, so that you can understand what you should be doing to protect yourself.
Mm-hmm. And then the last question, again on screening. If someone's feeling nervous about that process of going through screening, what would be your advice to them, and how would you ease their worries?
Again, I think start with your primary care physician, start having that conversation. And the reason I say that is because if you have identified somebody who you say is your primary care physician, you have already established a rapport with that person, you feel comfortable with them. Your doctor should be the one, I think, that you can say anything to and feel comfortable that whatever has been discussed remains right where it was. And so go and see that person, have that conversation. If you don't have a primary care physician, do your research, ask around, find a gastroenterologist and go and see that person. Have those discussions, let them know what your concerns are. At the end of it, the conversation, you will have a level of comfort. You should have a level of comfort. And if you don't feel as if you have a level of comfort from either your primary care physician, any physician, or the gastroenterologist, then that means that you need to move on to someone else, because it's just not that difficult. It should be very simple. If someone can't explain something to you in terms to make you feel comfortable with what is going to happen, then that person is probably not the right person for you.
Right.
I have this conversation often with my colleagues, and I say to them, just physician colleagues that are returning into practice, and those that are starting their practices, and I say to them, I said, let me tell you something. I call it the 2 C's. If people are comfortable with you and they have confidence in your ability, you will have no lack of work.
All right. So, great advice. Great, recommendations for those who may be of screening age or may have symptoms and are in need of getting screening done. I want to thank you so much, Dr. Moxey, for taking time out of your busy schedule to come on the podcast today. Where can people get in contact with you if they are in need of care with regards to screening, anything like that? Where can they reach out to you?
All right. Great. So again, I can be reached. I'm one of the vice presidents at Doctors Hospital for clinical services. So certainly if you contact Doctors Hospital, 302-4600, and you ask for me, they can direct you to me in that way. I'm also, my office number is 328-1119. I'm located Montrose Avenue and Arundel Street, and I'll be more than happy to take care of you and to answer any questions that you may have in this regard.
All right. Thank you very much, Dr. Moxey. All right. And thank you to our listeners. This has been another great episode of the podcast. As always, we encourage you to like, comment, subscribe, and share. And we will see you next week on the podcast.
Doctors Hospital is reimagined primary care. We have invested to improve our health system, ensuring that accessible, affordable, world-class clinical care is closer to you. Your relationship with a primary care provider shapes the foundation of your overall health. Our new, modern primary care facilities are where critical diagnosis and true personalized treatment begin. With locations across New Providence, Grand Bahama, and Exuma, we invite you to experience the Doctors Hospital difference. Book your next appointment at clinics.doctorshos.com.